This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat session for Monday, April 20, 2026. I'm Len Sierra. I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and all of you are well-informed attendees. As a reminder, this video chat session is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and they are Foundation Medicine, Novartis, Telix, and Blue Earth Diagnostics. So, Rick, we actually don't have any newbies, like, other than Cheryl.
Really? Wow.
Oh, okay. Well, we can take Cheryl first, but all right, that's fine. I'll make the announcement that I wanted to make, which is just that there's a new, we were approached today for participants for a new survey. They're looking for 10 plus or minus 15 men in total. 10 are hormone sensitive and 5 hormone resistant. So that's 15 in total. The only requirement is that you cannot have been on Orgovyx, Xtandi or Xalirutamig, or Talzenna, which is talazoparib, which is a PARP inhibitor. I don't think we have anybody on that PARP inhibitor. The pay is $200 for a 60-minute interview, so it's good money for 60 minutes. And they're trying to fill this up quickly, like by the 28th or 29th of this month. So it'll be in next week's reminder. If anybody is interested right now, if you send me a email, rd@ancan.org, with my, in the header, just put Flint's. I'll put this in the chat window in a second. Flint's, FLINCE. I will send you the details and who to call. And if anybody is accepted, just please let us know, because that will give us the opportunity to track what we receive as well, because we will get a donation as well as you. So again, hormone sensitive or hormone resistant men, you cannot have been on Talzenna, talazoparib, Xtandi, enzalutamide, or Orgovyx, and it's a 60-minute interview, and they'll pay you $200. Okay. So let me know. First come, first served.
Rick, was there any specification as to whether or not the person has to be on a drug regimen at this time, or could they be on drug holiday?
I asked them twice, and I said, is there any other restrictions? They said the only thing is no Talzenna, no Xtandi, no Orgovyx. So don't shoot the messenger. I went back and asked them twice to verify. Okay.
Very good.
And what I will do is put in, I'll just put something in the chat window right now, Flint's. And I thought I saw Danny Langford came in for a second as well. Yeah, he is there.
He was here.
Here, I'm on camera now.
Yes. Yes, yes. We'll make an exception for you, Mr. Langford. Did you need any time?
I told Lynn at the beginning, maybe at the end,
Oh.
if there's any
Oh,
free
okay.
time is available, but put me at the
we'll
bottom
give
of the list.
you don't go to the bottom of the list. We'll give you time. I didn't see you before. I thought he came in. All right. People who are emailing me in the chat, please send me an email. I asked you specifically, so that way I have a record and I write back to you, because it's too hard to, with everything going on. Just send me a very quick email, Flint's, yes, I'm interested, and I'll do it. So that goes for Dr. John, Bob Alvord. Just send me a quick email note, please. And Cheryl, I have to ask you, are you in here because you've got recurrence already?
Yes, Rick, I promoted myself to this group.
Oh boy. So let me give everybody a very quick update, and then you can fill it in, because I think I have notes on Cheryl, but some of you don't. But Cheryl came to us last year, correct? I think it was sometime the earlier part of last year, I believe. He lives in Birmingham, Alabama, and has a high-level government job and security clearance type of government job, and came to us. And I can't remember if it was through us doing the PROMISE study or you knew already, but it turned out Cheryl was BRCA2 positive. So I believe you were a 3+4 originally.
That's correct.
Right? Yeah.
That's correct.
And yeah. And so, we take, even in the active surveillance and low intermediate groups, we take germline mutations very seriously. And so we suggested that that Cheryl upgrade his care, and he actually went and saw Dr. Evstathiou. And between Dr. Evstathiou and Cheryl, they decided it was best if he could be treated by Jim Hugh. Was it Jim Hugh? Yeah, Jim
That's
Hugh at Weill Cornell with surgery. And what month was that?
August 2025.
August 25. And he's been doing well on the recovery. We've seen him a couple of times. He hasn't been a stranger. But now I'm very sad to see you in this group, and I'm going to hand it back to Len, and Len can ask more questions and fill in anything else, and we can see how we can help you.
All right, Rick, thank you. Cheryl, let's see, I guess if you're at Weill Cornell, you must be living in New York City or nearby?
No, Birmingham, Alabama. Len.
Actually, I'm in Montgomery, Alabama.
Montgomery, Alabama.
Oh, okay. And you traveled all the way up to New York for?
Yes.
Okay. And so what other treatment have you had besides the prostatectomy?
That has been the only treatment so far.
Okay. And what was the first PSA result after your surgery?
At the 3-month mark, I was a 0.06.
All right. And after that, 6 months?
I was a 0.15, and that's why I'm here tonight.
Yeah. Okay. And you are BRCA2 germline or somatic?
Correct.
Germline.
Okay.
Germline.
Yeah. Was your cancer contained to the prostate?
No, it had got out of the prostate. It had got into a lymph node.
Pelvic lymph node?
Sir?
Pelvic lymph node?
It does not. It says regional lymph node. I will-
Regional, probably pelvic. Yeah.
Yeah. So
Just one?
Yes. 3 lymph nodes were examined, and it was in one of those 3.
Okay. You say they were examined, so were they surgically removed at the time of the prostatectomy?
Yes, correct.
Okay. And have you had any scans, PSMA PET scans?
Yes. Excuse me. Yes, had one earlier this month.
Okay, and what did that show? Anything new?
Nothing new.
Okay. So you've been discussing what, salvage radiation therapy with your
Yes.
doctor?
Yes.
Yeah.
Yes,
Okay.
I have with my oncologist. He ordered the PET, and when we got that back, I went and talked to a radiation oncologist in Birmingham, Alabama, that I had met with before when I were first evaluating treatment options. And so he said that he recommended 7 weeks of IMRT and hormone therapy.
7 weeks. Okay. In addition to the radiation, or just?
7 weeks of radiation.
Oh, IMRT. Right. Gotcha.
Yes.
Okay. 7
Yes.
weeks IMRT and hormonal therapy?
Correct.
For how long?
Let me see. Did I get that note? I was writing fast. He was talking faster than I could take notes. I do not have that.
Okay. And you, I think Rick said you were 3+4?
Correct.
Reason, yeah. Okay, guys, anybody, I'll open it up to the floor. Anybody want to opine about Cheryl's choice here? Sounds good to me. Sounds like standard of care.
Yeah, I think the problem, Len, is that I don't know what standard of care if you're BRCA positive.
Right.
I don't know if it calls for more than 6 months. And I guess my feeling is, I know that you were seeing Dr. Efstathiou, and I know she's not too available, but I think one thing we should do, I will send you, I'll put it in the chat directly to you. I'll give you her email address that I know she's monitoring. And I think I would ask her what sort of regimen she recommends in terms of hormone therapy. Because I think that's going to be the complication. Was your doctor recommending 1 or 2 drugs for hormone therapy?
2, Rick.
Great.
Well, we'd like to see you on Orgovyx for one of those drugs. I can't remember. Are you a veteran, Cheryl?
Yes, I am.
Oh,
Yeah.
yes.
Okay, so definitely tie up with Captain Jim, because some of this you may be able to, if your insurance, I'm assuming you're on a federal insurance program, correct?
That's correct.
Yeah. So Jim knows a lot more about this than we do in terms of the insurance and the vets and the VA, but you can definitely get your Orgovyx through the VA. So if the federal insurance gives you a hard time, you can definitely get your Orgovyx through the VA. The second drug is probably abiraterone. Am I right?
I didn't get those names, Rick. Again, he was talking quicker than I could write. But
so
that sounds familiar.
Go ahead.
No, that's it.
Here's a tip. Record these meetings. Tip for everybody. Some of you do it, some of you don't. Ask your doc, tell them you need to record the meetings. That way, you're not under so much pressure to take notes, and you can listen later. It's too late now for this guy. Where is this guy that you're seeing?
He was at UAB.
At UAB.
Uh-huh.
And is he, does he specialize in prostate cancer?
Yes.
Yeah, I thought so. I know, because we've been around the mulberry bush a few times, so I figured you'd cover that one. Yeah, we need to know what the second drug is. Tend to say abiraterone, I think. I doubt that he's going to put you straight onto a PARP inhibitor. I actually will look for you and we'll see if there are any special programs right now on recurrence for BRCA2 men. In fact, maybe you should write to the BRCA brothers, send a note to the BRCA brothers and ask if anybody knows if there are any trials for immediate recurrence, because some of those guys follow that, and they might know more quickly than I do. But if you just send a note to that BRCA brothers mailing list and ask them, anybody know if there are any special trials for immediate recurrence after surgery, we might find something. I would really like you to write to Dr. E and ask her what she recommends. She's still not really practicing because she still doesn't have a license in Oregon. But she's real good about talking to her patients, if you can get to her. And watch the chat window, because I will definitely put Dr. E's thing in the chat window to you in a minute when we finish speaking. What else does anybody have to think, or does anybody know? Maybe Jeff Markey, maybe.
Jeff Markey had their hands up.
Yeah, there's a study for a new PARP inhibitor called Saruparib.
Saruparib.
Excuse me?
Saruparib.
Oh, okay. It might be possible that it requires you to be on what they're talking about getting you on, ADT plus an ARPI. But that's a possibility. I've got a link to information about the study. Just want to let you know I've had prostate cancer for 16 years, and I found out I was BRCA2 about 5 years ago. I've had surgery, and 3.5 years later came back and I had radiation, and I've been on a lot of drugs since. Do you have any heart issues?
Well, I do not.
Good. It's abiraterone. If you have heart issues, it could be a problem.
Yep.
What was your Gleason score? I missed that.
3 + 4, 7.
Oh, okay. That's what they told me before surgery. After surgery, they said 4 + 3. But yeah, I mean, you should have no problem handling the hormone therapy, and you may feel some fatigue and other issues, but I was on Abby for 2.5 years, and I'm on darolutamide now, and it's great. Darolutamide has just about no side effects. It's also called NUBEQA, Nubequa, NUBEQA. But they usually want to put you on Abby first. And I mean, Jim Marshall, who's the guy who runs the military site for him, was on it for 5 years, and it worked well for him. So for me, it didn't work that great. I was only undetectable 1 month out of 2.5 years. But I don't know if that was BRCA related, what it was, but that's how it worked for me. But it's I'll put a link into the. Rick, do you have any links on that Suparib?
I just know it's there, but we'll look at it.
I'll put a link in the chat about one of the articles about it.
Yeah, and I think that when it comes to whether or not to use a PARP at this point, definitely you should raise it with your oncologist. What's the name of your oncologist at UAB?
Dr. Andrew McDonald.
Okay, so raise it with Dr. McDonald, but also definitely ask Dr. E what she thinks about sequencing and whether to introduce a PARP inhibitor early or not to introduce it early. You know, this is really, I mean, it's obviously not standard of care. You are eligible for that PARP inhibitor. I'm pretty sure.
I think you have to be
resistant.
They have some early tests of it, though. There have been early tests for people that they're getting it first thing. I was going to mention that my oncologist has wanted me to wait till the last thing I do because of side effects. Regular PARP inhibitors have some really severe side effects on your platelets, on your white blood cells, your red blood cells. They can give you anemia. So it's especially when you're taking.
That's why I think you've got to get. But I want to just check with Len. You think you have to be metastatic, but
well, that
sensitive or resistant.
The trial that was approved by the FDA was for MCRPC patients, but
but you're going back to you're going back to Lynparza in 2020. What about the approval since then?
I couldn't answer that. I'm not sure.
No, there were more recent studies with people who are castrate sensitive, and giving it early.
Yeah, we'll look at that. You have Len. You have Frank on your list, right? I sent you an email on that.
Yes. Did he just arrive?
Yeah.
Okay, we'll go to Frank next.
The study that I'm going to put in the chat is about patients who are mHSPC, which fits him perfectly.
Right. So, again, Cheryl, there's possibilities with studies, but I think you've got to talk to McDonald. I think you've got to talk to Dr. Efstathiou. It's a tricky business. Just for the reasons that Jeff outlined, that the PARP inhibitors can have significant side effects, not always, but they can. So we just have to look and see. But keep coming back and keep bouncing things off of us, and we'll get you straight. We'll straighten you out best as we can.
Jim Marshall, did you want to say anything other than finding out if Cheryl is a vet?
Yes.
You did. Go ahead then.
Cheryl, have you determined your testosterone level yet?
No,
as a baseline. That would be a very good idea before you do the ADT. Okay? So just say, I want testosterone test, please, now. Okay,
Got it.
good. That's it.
And
And hopefully I'll see you within our veteran support group. Okay.
Roger that. Got it.
Yeah. Cheryl, are you getting the reminders for the veteran support group?
Yes, I am.
Okay.
Oh, he is. Okay. Well, I'll hopefully see you tomorrow night.
all right, thank you, Jim. Jim Stewart, what do you have to say?
I just want to make a quick comment on this. Our paths are pretty similar. I've got the BRCA2 prostatectomy in 2024. My PSA doubled from 0.04 to 0.1, which triggered a PSMA scan, and they found 2 lymph nodes. I'm getting my treatment at UCSF, and then they started me on Orgovyx March 1st, and then abiraterone April 1st, and then I'm having some spot radiation that's going to start May 11th. And that, what I wanted to really comment on is one of the disputes they had at UCSF was the original radiation therapist wanted to do the lymph nodes and the prostate bed. And Dr. Carroll said, no, that's not necessary. Just do the lymph nodes. There's no sense in doing anything to the prostate bed. That's where you get the real severe side effects. There was no evidence of any disease in the prostate bed. So don't do any radiation to that area, just the lymph nodes. And that's the advice I'm following.
Can I get this working yet?
Thank you.
Yeah, that's really good peer advice. And I just heard Dr. Carroll speak on Friday, and he was quite impressive. And, you know, he leans more, even though we know he's not a medical oncologist, I kind of make exceptions for Dr. Carroll. And he's working very closely with the medical oncologists and the radiation oncologists at UCSF. And Jim Stewart, that's really, really helpful information. Have you talked to anybody at UCSF about when to sequence the PARP inhibitors?
You know, I brought it up initially, and then I talked to Dr. Munster about it and Dr. Carroll's office, and they said, no, now's not really the time to talk about it. But I do have a follow-up appointment with the oncologist, Dr. Bose, next week. And I was going to bring it up then, just to see if anything had changed.
Yeah, that keep us posted. And what you're saying is that also Dr. Munster thinks that you should keep the PARP in your pocket at this point, right?
Yes, and that was back in January. We know how quickly the information is changing.
Yeah,
at that it was appropriate.
Okay, well that's good, because Cheryl, Dr. Munster, who's on our advisory board, is a real expert in BRCA2, not so much in prostate cancer as in other diseases. But you know, I would value her opinion on when to sequence PARP inhibitor. That's very helpful.
Dr. John, you had your hand up, but now it's down.
Well, I was going to say that I would probably, if an additional drug was necessary, I think if it was me, I would rather be on docetaxel and then a PARP inhibitor. And then I took my hand down because I thought it's kind of early for that kind of discussion. Cheryl, you've been to Men Speaking Freely, haven't you? I know you're from somewhere.
Oh, not Men Speaking Freely. I was in low and the intermediate group.
Okay, maybe that's where I. And when you pronounce your first name, do you accent the first syllable or the second syllable?
It's Sherelle.
Sherelle. Okay, thank you.
All right. Sherelle, thank you very much. Is it okay if we move on?
Yes, yes. Thank you very much, gentlemen. I found this very helpful this evening. Thank y'all.
You're very welcome. Thank you. Let's see, I've got Dr. Jack first on the list.
Okay, so long story short, but as you all know, 23 years ago, almost to the date, I had a prostatectomy. I was clean for 15 years. It came back biochemically, slowly, methodically. They found it with a biopsy in my subcarinal lymph nodes and I very emphatically said to the people who were in charge of my treatment, I wanted metastasis-directed therapy. I didn't use the term back then. I said spot SBRT without hormone therapy. I begged them for it. And I cited literature saying that's all I really needed because I had an indolent, slow-growing thing going on. But there's a lot of forceful thinking is up north in certain places I don't even want to describe. I was said, it's not going to work. The radiation therapy will not work without the hormone addendum. So I went with the hormone addendum for 2 years. At my age, I'm now going to be 87. And of course, I have, after 2 years and 13 months drug holiday, I'm not having any testosterone recovery. And what I'm having instead is my worst nightmare, which is bilateral atrial dilatation. Both of my atrium are dilated so drastically. They've gone from, my left atrium has gone from 40 to 58, okay, over the past pre-treatment level to where I am today. And my right atrium is following that, which is a harbinger of congestive heart failure, which is almost a fait accompli. And I don't know what to do about it much because I was considering all the options, including going on TRT. I tried the clomiphene with Dr. Belusic's coaching. He was hoping that could be helpful in reversing some of this cardiac remodeling negatively, but it didn't work. My testosterone didn't recover. And now it's bounced up to about 70 from 26. So maybe there's hope there'll be some recovery. I'm willing to go all the way with the testosterone replacement, even though it's so frowned upon, because my life's on the line, and I want to build whatever cardiac muscle I can to prevent this sarcopenia from progressing and dilating more to the point where my heart becomes totally dysfunctional or I go into some bad arrhythmias. So I've made an appointment with Anna Barrick, who's probably the best cardio-oncologist up in Virginia at Inova, and she will be seeing me thanks to Dr. Belusic. They're old colleagues from NIH. And I even threw in the fact that I was at NIH, and it kind of helped. And they're squeezing me in early May, and I don't know, maybe I'll fly up, maybe I won't. She may be willing to do it, although she's not licensed in Florida, but she may be willing to squeeze me in telehealth, and I may want to go see her after that, or maybe even in lieu of that. So what's been reported in the literature is that when men don't have testosterone recovery, their chances of overall survival are diminished compared to men who do have testosterone recovery. So that's not too hopeful. The other thing was, I thought of the possibility of maybe estrogen. Everybody's been talking about estrogen, but then I explored that, and I use a lot of open evidence, which is the best artificial intelligence for doctors alone. And it said basically the literature on estradiol patches is very effective for women who want to rebuild cardiac muscle, but for men it's just the reverse. What happens is that if men take estradiol, it'll actually aggravate or enhance cardiac remodeling in a negative direction. And the only way to reverse it, and it would be to do testosterone or have testosterone come back, or there's some new drugs out. I don't know if Dr. Barrick's familiar with it. One I've never heard of, maybe some of you have heard of. They're called SARMs, SARMs. And the good thing about a SARM is that they allow you to get the anabolic benefit and the anti-androgenic effect at the same time, but they haven't been approved. There's one endobarsim, and I don't know whether there's any clinical trials where SARMs are available, but they're not approved by the FDA at this point, but it's hopeful if they ever are approved, because they can make a difference in reversing sarcopenia and also not impacting your cardiac or your prostate cancer. So I was hoping Dr. Paul was here, get a little feedback from him. He's not here tonight. I'm disappointed. Maybe I'll talk about it again. This is a pretty hairy situation. I'm not sure you guys can be that helpful other than say, yeah, tough break, I know your group. I appreciate it. I wasn't aware it existed. I see how many people have cardiac problems. I've always been aware, and I've always said to Dr. Belusic, this treatment's going to kill me, not the prostate cancer. I guarantee it. He shook his head and he said, you're right. That's where we are, and I hope I stick around, but it's kind of scary.
Yeah, thanks for sharing that, Jack. I have to say, of course, we don't give medical advice, certainly not to a doctor, but if it were me, I'll put it that way, I think your choice of testosterone replacement sounds reasonable. Of course, Dr. Barrick will be your guiding light here, I guess. Anybody else want to say anything to Jack? Oh, John, go ahead. Dr.
Yeah,
John.
I'm probably going to ask Alfredo for some help here, but so we're presuming bilateral atrial dilatation due to myocardial sarcopenia with no ventricular dilatation. Now, one thing I don't know about ventricular dilatation or dilatation cardiomyopathy is, when it happens in the ventricles, it's, all the things that you talk about, begin to have a little bit of heart failure, have jugular venous distension, get tired, blah, 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 and all that stuff. What I don't know about the classical ventricular dilatation that we all know and hate is whether it typically starts with atrial dilatation. And I also don't know whether atrial dilatation is in and of itself, outside of maybe causing arrhythmias, is that bad?
It depends on the degree of fibrosis. And if how do you assess fibrosis? I don't know how to do that. Maybe there are certain scans that can determine the degree to which it exists. But when it becomes very fibrotic and thickening, and it's no longer able to have the flexibility and it's not gonna pump very effectively, and there's going to be a lot of regurgitation back into the ventricles, and then I'm sure it's going to have an effect on the ventricles. So
Why would it have an effect on the ventricles?
Well,
so what if the atria get somewhat enlarged? Maybe there'll be a little back pressure on the veins going into the heart, but does that progress to the kind of cardiac dilatation that we worry about? And
according to open evidence, which I'm starting to respect more and more because they have very sound, they draw from medlars and all the medical stuff. They said yes. They said yes. And they said you've got a real competing situation where under your circumstance, the tumor board should really be discussing whether or not TRT is the best option for you. And you're willing to take the risk because the odds of dying of prostate cancer at this point are much less than dying of cardiac diathesis.
And the other question I had too is that you mentioned remodeling. It's, remodeling for everybody else sounds good, but it's bad in the heart. I also don't know about the phenomenon of atrial remodeling because everything I know about that is ventricular. So somebody, if anyone knows these things, I would love to know more about it.
Atrial remodeling was what caused the problem. And it could have been related to, I did have atrial fib, but it was not chronic. It's paroxysmal. I had an ablation in 2013. I only had 3 or 4 episodes when I had the ablation. And I haven't had a lot of atrial fib. And so, but it could have caused some scarring and remodeling. And And now it's a matter of getting reverse remodeling. Can I reverse back? Can testosterone do that? And, cut the size down from 58, went from 40 to 58. That's huge.
It's huge.
Thank you.
Let's go to Rick and then Alfredo and then Larry.
Yeah, I don't want to go down a rabbit hole here in this group with the estradiol E2 JAK, because at this point in time, it's not relevant to your situation. It could be very relevant if you relapse.
Absolutely.
But thank goodness you're really stable. You don't need drugs right now. So the biggest issue is not whether or not estradiol is appropriate. That's a discussion for the future. The biggest issue is how can we strengthen your heart? And maybe if one way is through testosterone replacement therapy, what effect might that have on your prostate cancer? So I just, I'm just throwing that in terms of your discussions within the group about estradiol and with Dr. Paul.
Right. Well, I just thought it was interesting about estradiol it threw me for a loop because of the negative effect it has on men if you use it when it doesn't have that effect.
Right.
Ah, very interesting.
Well, Jack, I wish I could offer some wisdom here, but first of all, I want to thank you because you're teaching the rest of us a lot. You're out there on the frontier. I wish I knew a cardiologist, so I could give you a specific name of a cardiologist who would be perfect to talk about this situation, because I think some cardiologists out there will have a strong opinion about this and some experience. I don't know who that is. Have you found somebody?
Alfredo, most cardiologists don't know squat about this.
Yeah.
I'm seeing that the major cardio oncologist in the country he's been doing this for a long time. She's double board certified in oncology and cardiology. And she's up at Innova, Fairfax. Her name is
Anna Barak, right?
Anna Barak.
Yeah. Well, I guess you're in good hands. This is way out there on the frontier.
Sure.
And I would love to say, oh, well, we know, from decades of experience exactly what the clinical history is here. But gosh, I don't know. I don't know.
Yeah.
But I kind of agree with Rick. I think estradiol E2 is probably the least of your worries here. And when are you going to see Anna?
May 5th.
Yeah. I think we're going to learn a lot from that visit.
Yeah, and I just want to add, we know Dr. Moslevi very well, who is another leading cardio-oncologist and one of the very first cardio-oncologists in the country. And Dr. John knows him. We know him. He's at UCSF. He's really good. So if you want...
Moslevi?
Yeah, Moslevi, isn't it, John? John?
I don't remember the spelling. It's a very odd one.
I have it. I'll put it in the chat window for you.
I had to practice it before interviewing him that time because it's. I did. I had to say that name over and over again, and I was stumbling on it. Muslehi.
Yeah, he was. He was in the UCSF webinar on
really
Friday. And
I tuned in the afternoon. I missed the morning sessions.
So here's the spelling: Moslehi.
Moslehi, that's it.
So instead of an Israeli name, Moslevi, it's probably a Persian name, Moslehi.
It is Persian. He's probably Persian Jew, I would guess.
Yeah, and I think he's, to the extent this means anything, which I don't know if it does, he's the chief of cardio-oncology at UCSF.
Yeah, so, he's a good guy.
Up there with Dr. Barak. Like, boy, I wish the two of them on this call to say, okay, hey, what do you guys think? Because there's very few people whose brain can absorb what we're talking about, Jack, with you.
I think we have a really good chance at getting Dr. Mosley onto our advisory board and to give us a webinar at some point. So
That'd be great. That'd be
watch
terrific.
this space. And I'm just putting it in the chat window for you right now, Jack.
Yeah, there we go. Yep.
Yeah, he knows AnCan. We've just sent another patient down to him.
So, Larry, I hope you're not going to mention estradiol, but go ahead.
Not well, only peripherally. I'd love to read the research that Jack found that says that estradiol is dangerous for the atrial remodeling. And my email is in my name, and I just sent a message too. So that was it.
All right. I'll send it to you.
Thank you.
Send me your email.
Okay. Once again, thank you, Jack, for sharing.
Thank you. Thank you for listening.
And we will go to Jay Mills.
I have a meeting. I should be on now. I have a. I need to do my homework. I need to pick a GU oncologist, and that's probably my main need right now. I am still I have signed up for the NCI trial. People who have current PSA, but with and PSMA positive. I'm not yet PSMA positive, but I've gone ahead and signed up for the trial, and I just have to get another PSMA scan. That the one I had locally was not dedicated, as they call it, which I think means full strength, and so we're going to wait to 6 months after the last one and do that in June, and then I will be officially in. The only real hurdle I have is the next scan I have is in a couple of weeks, a bone scan. And if that's clear, I'm in. If it's not clear, I'm not in. So, but I don't anticipate to be PSMA negative and bone scan positive. So then I have my urologist I meet with. I haven't met with him since I had an MRI, that he said if you see something with a 3 on it, 3, 4, or 5 score, he would want to biopsy. And so I'm going to have a conversation with him day after tomorrow about that. He'll want to do a biopsy and I'll want to not. And at this time, I'd like to learn more about it. Is this the right time, how to do it, and who to do it, and don't know who to ask all the details of. And wondered if you guys have any recommendations for that. It probably should be my medical GU oncologist that helped guide me on that, and that's where I wish I was.
Yeah. So I would say a couple of things on this, Jay. What is the benefit of getting a biopsy from your perspective? Why would you want a biopsy given what your PSA is doing and where you've been following it?
The benefit would be that if it is confined to the prostate, then it would be a benefit to do focal treatment. And the likelihood of it's not is, I think, slim, but it'd be hard to find anybody. I have not figured out how to figure that out.
Okay, but what we're seeing right now is in the prostate, correct?
That's right.
So I don't even know to the extent they could do focal treatment in the prostate after it's been treated with, did you have HDR or seeds? I can't remember.
HDR from SHU, and then
yeah,
IMR,
from SHU.
Yeah, IMRT in 20 months. Yeah.
Right. But the the prostate's been pretty much blasted with HDR.
Yes. Yeah.
I mean, maybe if we could get Dr. Munster to give you one of her capsules with enzalutamide inside it and stick it inside, and which she's testing right now. Maybe she'd do an N=1. Maybe NCI would do an N=1 with you. By the way, that they're testing her what's it called? Enolen, ENOLEN, I think it's called. I wrote it up a couple of weeks ago.
Okay.
They're testing that at NCI. Pinto is running that trial. So you wouldn't be eligible for the trial because it's not for somebody who has recurrence, but it's possible that between us and NCI, we may be able to get you an N=1 there, and stick one of these enzalutamide capsules inside your prostate. That could be interesting, but I don't see the reason to do. I don't see any reason to do it. I mean, if it was outside the prostate, yes, because then we could shoot it.
Right.
I'm not so convinced inside the prostate.
I've read that what's the fellow's name at UCLA? The
Tishan.
Yeah, the Tishan is doing with people who have had brachytherapy or radiation to the prostate. It may be other forms of radiation to the prostate. I'm not sure what form it is. I don't recall, but that he does. He sees benefit in going in and doing focal radiation on top of radiation, although it's risky. I think I remember reading that.
Well, I mean, to me, and I'd be interested to hear what the other people in the group think, but to me, if you're watching that PSA very, very carefully, which you are, because that's the whole point of the trial.
Right.
And you have a GU medical oncologist right now in Dr. Abel.
That's true. Yes.
Right?
Yes, that's right.
And excuse the pun, I would say she's very able. and so, yes, you can go find somebody else, but you don't necessarily, you've got two, then you've got the issues of, well, who's in the lead? Who do I listen to? I mean,
yes,
we've got good docs, and they're all going, I've given you names of people who respect QOL, but for me, I'd go with Dr. Abel. I'd have that chat with Dr. Abel about, well, do you think that Dr. Munster's Enolan could help me or not?
Mm-hmm.
And I just watch it.
Yeah.
What about you, Len? I mean, what's
I was just thinking that Jay must be seriously conflicted because on the one hand, he seems very anxious to do something. On the other hand, he's enrolling in this trial where they're saying, don't do anything.
That's right.
So,
that's right. Yeah.
Yeah.
And I'm conflicted in that I think it's more of confronting my urologist who has his protocol of what to do next. And I have confrontation with him today after tomorrow, and that's what he would do. So and it's a what they see on MRI, and it could be the halo effect of the dye masking what did light up with PSMA. That would be worth seeing it if we would run a different type of PSMA, like the 1007 PSMA, or the one that Blue Earth just advertised recently about that has, or there's I think the one 1007 is the one. Both of them reduce the halo effect, so you can see something light up with PSMA before you have the urine come through. Anyway, that would be a way to see it. The other is he used a PIRAD scale when you should have used a PIR.
But we're getting into weeds that you may want to get into. We don't need to get into, Jay.
That's true. That's true.
My question is why?
Yeah.
And my question to your urologist would be why? I mean, I wouldn't even be seeing a urologist at this point in time.
Right.
You know, we don't feel you can rely on urologists on recurrence, and certainly not local community urologists. You know, if this was a guy that was at University of Chicago or the James or somewhere like that, okay, but you're spinning your wheels with him and he's sending you down rabbit holes, and I don't think that's where it's not where I would want to be, because we're losing the real focus, and the real focus is, do you need treatment now or do you not need treatment? And even if he confirmed that it was prostate cancer, we're still back into, well, it might be prostate cancer, but your PSA is moving so slowly with it.
And the other aspect of it was the when I asked Abel about it, about this, she said, well, we talked about that they do allow for you to have salvage, and that you stay on the trial, but that they also would want you to work with your medical oncologist. So she's thinking that while she is a medical oncologist and a GU medical oncologist, they would want you to have one outside of there as well, one outside of the NCI, as I understand.
Well, if they do, I would be, as I said, I'd be going for somebody who really is big on quality of life, like Chowdhury or Schmulowitz or Dan George, who really make that a priority. I am going to put the Enolan announcement.
Okay.
I'm going to put two of them, but I'm going to put it in the chat window. But recognize this is not really for your situation. This is for a situation of somebody getting it before surgery. Now, as Jeff Markey pointed out to me a couple of weeks ago, in practice, it's never going to be given before surgery. It's a dumb trial. We're just trying to prove. We're trying to prove the viability of Enolan. In practice, it won't be given. It'll be instead of surgery, in conjunction with surgery. It'll be given instead of surgery in the long run. But it'll give you an idea, and it'll allow you to ask Abel, what do you think if we stick one of these inside my prostate?
Right.
You know, it's a long old, it's a long old, it's a huge URL.
Mm-hmm.
I'm afraid, but that's for Enolan, and I'll put what the company said about it too. And you know, I can ask Pamela, could we get a capsule? I can ask her, you know, what she thinks about that.
Well, Rick, if you do have time, I'd love to talk to you about Chowdhury, Schmulowitz, George, and others sometime.
Well, yeah. I can talk to you, but I think that you have what I'm thinking, which is all three of them care about quality of life.
Mm-hmm.
And I don't really have a preference between any of them. You know, who would I don't know who I would go to. I think they're all good because they're all concerned with maintaining quality of life. We know Schmulowitz because he treats David and other people and he minimizes treatment. Atish has got this. He was one of the first people to look at how can we minimize the amount of hormone therapy, and he cares about that. And Dan George very much cares about minimizing treatment. So I don't have a preference between them, Jay. I don't know what else I would say to you.
Okay, very good, very good. Yeah, just to hear more about what they're like. And so anyway, thank you for your help. I'll also listen to what others say about these and other guys. Thank you.
Okay, thank you, Jay. And we will go to Frank Chambra. and then Joe Commanda after that. Go ahead, Frank.
Oh, Mrs. Frank. Hello, Mrs. Frank. She exists.
I only come in when it's important.
She exists. We thought you were a figment of Frank's imagination. That's what we thought.
It's my better half.
Welcome, welcome, welcome.
Thank you.
So what's going on is I've talked to Rick about it some this week, and I spoke in the group on Thursday night that I received the cabitaxel arm in the clinical trial, and I'm a healthy guy. I'm 60 with all I've been through, all the treatments, the Pluvicto. I've been through chemo. I've been through Lynparza. I've been through Alita, everything. So I'm a healthy guy. I'm still active, still functioning, and I'm afraid that if I take this cabitaxel in the trial arm, that I'll be committed to it. I'm afraid it's going to like debilitate me and make me worse than I am. So we got the information from Rick to get
We got it all. And I think it's really going to help us because we feel the way Rick just helped state it, that we don't feel we have time to go through the trial with the cabazitaxel. And I do think it's really important. He does need another liquid biopsy. In trial, we'll never get that if we go in the trial. And he does need another biospecific, monoclonal antibody similar to Xalirutamig. I agree with all that. So that's what we're going to talk to Dr. Yang about Wednesday morning. We'll do the cabazitaxel. We're not against it, but I think that there's something better out there for him.
Yeah. Yeah.
Did anybody else lose audio, or is that just me?
No, it was good. I had it right the way through that. I'd like to ask the moderators and those of you who follow the literature here, any ideas on other trials that might use a bispecific monoclonal antibody, but different proteins, different mechanisms. I know that there's other stuff being tested, and I haven't had a chance to sort of go in and look, but we could use some good research here as to what other trials are available for Frank. Two things that I did point out to Frank is, one, you can always walk out of a trial, always. So you're not committed to staying in. The sub point of that is that for the interim, a lot of the guys really tolerate cabazitaxel very, very well, much better than they tolerated docetaxel. And I've known guys stay on it for years, like a couple of years or more, 3 years. So yeah, it might be good. It might work for you. And it's probably not going to interfere with any trials, which is any other trials, which is a good thing. The other thing is that I think we've got to be looking for other targets. And
yes,
my notes said 23 or 24 was the last time you had that.
23.
Target.
Yes,
23.
9 of 23. Yes.
So you've got to be looking for other targets. I wouldn't go with Garden. I'd go with Tempest probably. Or one of the others, but I think we've got to be looking for other targets. And then if we find a target, then we can see if you're eligible. If P10 is in there, you may be eligible for Capitello. And the likelihood is we're going to see P10, TP53, or RB1, unfortunately. Anybody else?
Hey, Frank, the drug you wanted was an anti-STEAP1, correct?
Yes. Yes.
And did they positively identify that as one of your, that's a
No.
protein or an antigen that you have? Oh, they didn't.
No.
See, that's a big gamble. Like, why would you
They-
give
they
somebody?
did-
Why would you give somebody a drug like that, which has serious side effects, if they're not even sure you have the antigen that would make it
Yeah.
work?
Yeah, they did not. They did not. No.
That's crazy. Wow.
Just to explain what Len was saying, for those of you who are sort of lost, this Xalirutamig is attracted to a protein on the surface of the prostate cell, which is called STEAP, STEAP. I forgot what it stands for, but somebody will know. And what Len's saying is, well, why don't they test to make sure that he has that, he's expressing that STEAP protein first, but they haven't done it in the trial. This AMG 509 has been going a long time. I mean, we had a guy who was on it 2 or 3 years ago. Right, Len? Did I misstate anything?
Yeah. I mean, just to make it clearer to the other guys here, this to me, this would be like giving somebody lutetium PSMA treatment without even testing to see if they're PSMA positive.
Right.
Okay.
Makes no sense.
Yeah, in the trial, that is not anything they tested for. It's not in any of the literature we signed, paperwork, nothing.
Is there any chance you can ask them for if Frank could be tested for the STEAP1 antigen?
We can when we see them.
But why, Len? He's not going to get the drug. He's
we're
been
not
assigned
getting
to
the drug.
he's been assigned to the other arm anyway.
Yeah, but if they found out he was positive, they could say, "Hey, look, I'm the perfect candidate to get the drug."
Well, yeah, but I don't think it works like that.
It doesn't.
Yeah.
We would have to get a second opinion, I feel, and go somewhere else.
Yeah. You've had docetaxel before?
Yeah, he had three docetaxel and he did not respond at all. His PSA rised each time after 1, 2, and 3, and then they called it quits and we went to Pluvicto.
Yeah.
Okay, so then that's another point of argument you could make. You could say, look, these taxanes, they're both in the same category, the chemotherapy,
Right.
They're both taxanes. They don't appear to work for me. I don't want to take this chemotherapy drug. I don't believe it's going to work. And I'd really like to be tested for the STEAP1. It's worth a try. You got nothing to lose. You don't want to do the chemotherapy anyway.
It's not that he wouldn't do the chemotherapy. It's that if in the trial he does the chemotherapy and they're not going to look at anything else while we're in the trial beside of what's laid out in front of us, I'm pretty sure that we can't get a somatic liquid biopsy in the trial. I mean,
no, you'd have to ask for the somatic liquid biopsy before you entering the trial, and I really think you should.
I think we should do.
If they're hell bent on giving you cabazitaxel, you can get that anywhere. You don't need to be in that trial to get cabazitaxel.
Right, and Dr. Yang can still do the cabazitaxel, and we can do it not in the trial, and then maybe get the liquid biopsy, and then go from there. And like Len said, or no, Rick said that ask for some, prospective trials that we could consider.
Yeah, I think you've got to lean on Yang to give you some other trials. I mean, one of the problems is they want to fill the trials in their own hospital, but they've got to be bigger than that.
Yeah,
they've just got to be bigger than that. I mean, if we sent you to one of our favorite docs, we know that those docs would say, "Look, this is what we've got here, but this is what's going on elsewhere. We want to give you the best."
Yeah. I mean, and we're willing to travel to get a second opinion. We're not against that.
Okay.
We're not.
Let me ask Len, who do you think? I gave them a couple of names, but let me ask Len and John and anybody else here. I mean, who'd be a good person for a second opinion for somebody in Frank's situation, Len? Any thoughts?
That's your forte, Rick, not mine. I don't really know.
Yeah, John.
I was just looking up where Frank lives, Ohio, but I guess that doesn't matter that much.
I mean, we're 20 minutes from Columbus Airport. We can go anywhere.
Yeah.
How about Alicia?
Alicia Morgans?
Yeah.
Or Eleni?
Alicia Morgans.
Alicia? I think if I was sending him to Dana-Farber, I'd send him to Atish or Ellie, because I think they're more bench I mean, this is really people who are more buried in the bench than she is. She's more of a survivorship doc. You know, I was thinking possibly Antanarakis, possibly Sartor. He's not a favorite, but I think, you know, he's very knowledgeable about treating after Pluvicto. I mean, the guy I really would like him to see is Morris, but I don't know how to get to Morris. You know, Morris, Memorial Sloan Kettering. I think that's somebody I'm thinking of, but I don't know who else to send him to at Memorial Sloan Kettering. Dana.
Memorial Sloan Kettering would work because I have family in New York that we can stay with.
Well, there you go. Well, I think, you know, Michael Morris is there, but he's really not taking patients, and we don't have a good enough relationship with him to lean on him. What about Dana, Len? Do you think Dana would be a good person for, you know?
Yes, I do. I think she would be very good.
Okay.
Dana Rathkopf.
Dana Rathkopf. I'll put it in. I'm going to put it in the chat window for you right now.
Okay.
And she knows us, and I will write to her tomorrow.
Okay.
Or Len, do you want to write to her?
Sure.
You maybe have a better relationship with her than I do.
I can do that, yes.
Sign my name as well. I mean, we'll write to Dana and we'll say, this is that, you know, you've got, how many Pluvictos have you done? It's a world record. 10? 10
Pluvictos.
10 Pluvictos. You get a glowing forehead for 10 Pluvictos.
He does. But that's the thing, you know, we're getting to the end of, like, there's no much standard of care left is cabazitaxel. And if we don't get more information, then I mean, he's healthy and we need to treat him while he's healthy.
Yeah.
I just went over the inclusion criteria for the study, and you guys are, as you know already, correct. There's no requirement to have any particular biomarker.
So, yeah, I mean, look, I think that Dana would find you the right trial, even if it wasn't at MSKCC. But they're also doing so many trials at MSKCC, and she's really nice. We know the way we know it. Len, explain how we know Dana.
Yeah, I was mentoring someone who had neuroendocrine cancer, prostate cancer, and he was being seen by Dana Rathkopf, and eventually he went into hospice, so she kind of lost connection with him. So she called me up and she said, Len, what happened to Richard? I haven't heard anything about his condition. How's he doing? And I said, "Oh, I'm sorry you didn't hear. He is in hospice now." I'm sorry. No, I said he was in hospice and he died. He passed away. And she was crying on the phone with me. And she said, "I'm so sorry. No matter how long I do this, I still take it very hard." So, I mean, you can't ask for more compassion than that.
Yeah.
But she's somebody who really cares.
Yeah. And we have another connection to her too, which is David Muslin's good buddy of David Muslin's has known her since she was she was being pushed around in a pram, you know.
So once, should we reach out to, or wait till you reach out and then we would reach out to her?
Well, I think we should reach out first, right,
Okay.
Rick? Yeah.
Yeah, reach out
Okay.
and ask if she'd see Frank, and if she would see Frank, what's the best way to make? And sometimes they'll say just contact me directly, or sometimes they'll say go through here. But yeah, wait on Frank, and give her my best as well, Frank, when you write to her. But yeah, I think she's doing a lot of bench work. She's really in the lab as well. I think
Okay.
I know you like her. Yeah.
So it wouldn't be unreasonable, you think, if we did start the cabazitaxel just to hold us over until we figure out what's going on?
I can't give you that medical advice. I mean, if it were me, I wouldn't be averse to doing cabazitaxel right now.
Okay.
I think the very first thing I'd want to do this week is get some blood taken and let's see, because something might come back in that. I wouldn't start the cabazitaxel until I got the results of this of this test. I mean, they'll do it again at Memorial Sloan Kettering, but they do it in their own proprietary thing. So it's not bad that you have two, because Memorial Sloan Kettering has their own lab. But I really think, I mean, it's sort of disappointing that Yang hasn't ordered a trial, a test in all this time.
No.
All right. And Dana's information is in the chat window. Okay.
All right. Thank you.
Thank you very much.
Okay, thank you. We're going to go to Joe Comanda next.
Hi. I had a couple months ago, I guess, after hearing the program with Dr. Melissa Abel, who we've talked about already this evening, I had gone for a consultation with her, and she had encouraged me to go on holiday, or told me I could as far as she was concerned. So I went back and talked to my medical oncologist at Fox Chase and kept her aware of, my conversations and so on. And she told me I could. And so I started last week. I've been on Orgovyx for about almost 2 years. October would be 2 years. And then the Nubeqa since September of last year, I guess. So I was taking both of those and I just went off them. I don't know. I guess I don't really have, new results to tell you about, but I wanted to tell you I'd done that.
So Joe, you've been undetectable for how long?
Pretty much since I started on the Orgovyx, within a month or two.
And so that was 2 years.
Yeah.
And
going on 2 years.
Yeah.
Year and a half.
Well, yeah. So Dr. Abel said, you spoke to Dr. Abel. She said, you should join my trial, basically, right?
Well, I don't think I can join the trial because I've already been on these medicines. I think she's interested in people who have still not taken this medicine.
Is that right, Rick? I thought it was for people who Oh yeah, wait a minute. You don't have. You need to have a BCR, a biochemical recurrence.
Right, and you have to be. I think you have to be 12 months free of hormone therapy to be
Okay.
eligible for her trial.
Right. Well, anyway, so her advice to you was go on a drug holiday, right?
Well, if I wanted to, let's put it that way. I mean, she thought I could do so, and my doctor was in agreement with that.
Yeah.
And I guess we're waiting for the PSA to come back, and to the point at which I would go back on the drugs would be if it doubled within 6 months.
Yeah. Sounds like good advice to me. Are you okay with that? Are you nervous about?
No, I'm really not nervous. In fact, I thought I might chicken out at the last minute or something, but when I heard about it, I was elated. So,
Yeah, good.
We're happy for you too. You've never been very happy taking any of these drugs.
Right.
Okay. Anything else, Joe?
Yeah, I'm going to ask this question. This is like off the wall, but I take my blood pressure and pulse every morning pretty much. And my pulse has been going down there. I run and walk a lot. So it didn't bother me, but I just went to talk to a new primary care doctor today. And she was concerned because I'm down close to 40 for my pulse.
What was the pulse?
Well, close to 40. They had to take it a couple of times to get it over 40. But I myself am consistently in the 40s. I haven't hit 60 in a long time. And I've always had kind of a low pulse because of running. So it didn't bother me, and it doesn't seem to be, as far as I can tell, bothering my health.
And you don't take any medications that might lower your blood pressure? Yeah, you're muted, Joe.
I don't know what you heard or didn't hear, but I'm not taking any blood pressure medicine, for example. Never have.
Okay.
No beta blockers.
No beta blockers. Yeah. No. Do you have any postural hypotension? Do you ever feel faint when you stand up from a sitting position?
Not really. I mean, I have had that happen once in a blue moon, but not really.
And Joe, have you been a runner for many, many years?
Yeah, I have.
Well, I'm tempted.
But when I was running, I was in the 60s. I mean, when I was in my prime, shall we say, I would be in the 60s, and they would be surprised because they'd say, "Oh, you must be a runner," because it wasn't 70 or whatever. But 40 is kind of low. Is there any connection? I never paid much attention to my blood pressure until I got on the drugs. And so since I got on the drugs and I started having the lower blood pressure, I don't know if there's a causal connection or not. I just wondered if anybody knew.
Well, Joe, what is your blood pressure? If your pulse is 40, what's your pressure?
It's about 110 over 60, something like that. I mean, it varies somewhat, but of late, which is also low.
Yeah, but it's I've had that pressure for years.
Have you?
Yeah, 110 over 60. My pulse is more like 60, not 40, but my blood pressure is the same as yours.
Oh, okay.
I don't know, any MDs in the room who want to opine here?
I hate to stick my neck out, but Joe, it sounds pretty good. I wouldn't compare you to the general population, which is how we get the guidelines. I would compare you to the athlete population. I would love to know what the averages are, what the bell curve looks like for people who run 5 times a week. I don't know.
Right.
But you might be in that group, not the typical people we see in the office.
Right.
Bjorn
Joe.
Borg was famous for having a low pulse. His pulse was about 43.
Wow. Well, he's right in my neighborhood.
Yeah.
Joe, when I was running marathons, my pulse wouldn't go lower than 48.
Oh my
resting
goodness.
pulse.
Wow.
But 40 is awfully low. And you're still, how many miles a week do you run?
Oh, I'm not running that much right now. I mean, I'm mostly more walking, you know. So I do like 6 miles a day, something like that.
It's pretty low. Have a large heart?
Yeah, Joe,
Can
do
I
you have any
have a
cardiac
comment?
studies? Do we know how big your ventricles are? Do we know what your ejection fraction is? Anything like that?
Yeah, I don't know. I am going to see. He's not an oncologist, but he is a heart specialist tomorrow.
Oh.
Who I haven't seen in a couple of years. So I mean, all I saw him about was going on the statin medicine for my cholesterol.
So that'll be very interesting to see what he says. But
Yeah.
if you feel good and you're able to perform, you're able to run.
Yeah.
It's hard to go down the path of, oh, we need to prescribe something for this guy. That's a high barrier right now. You look good, you sound good, you say you can run without any difficulty. You probably have a ventricle that's pumping pretty well, and it doesn't need more beats per minute.
What if he had an AV block, Alfredo?
Hold on a sec. Hold on a second. Hold on a second, Dr. John. Dr. Russell, you've been trying to get in for a while. Go ahead.
Yeah, I'm on the wrong screen, but I mean, I would like to know what the EKG shows. I mean, there may be some kind of a block. And I mean, there are people that need pacemakers, and you know, he could be in great shape. But I'm glad to hear that he's seeing a cardiologist, because it's to me that's not a good pulse. I just don't think it should be dismissed, and I would want to know what the EKG shows. Has that been done, and do we have a result? And definitely, if I had that pulse, I'd be very worried about it.
Joe,
Okay,
do you
I
know?
don't want to spend a lot more time. If people have things to say, I guess it's okay. But I just wanted to throw out whether it might be related to the drugs, but it doesn't sound like you guys think it is.
Well, I don't think so.
Yeah.
Dr.
You'll
John,
likely get tomorrow when
Dr.
you're
John,
prepared.
what were you thinking?
I was going to say basically the same thing as Russell. You could, the 40s is a ventricular rate. You could have an atrioventricular heart block and still be pumping in the 40s and potentially feel okay because the ventricles are so strong. It's just something to rule out, which you'll get done tomorrow.
Right. Okay, thank you.
Hey, Mills, go ahead.
Unmute, Jay. Unmute. Start over, unmute.
In the daytime, I'm 60s and 70s, but at nighttime, I go into the 40s. And so I'm curious what your nighttime must drop to.
I don't know. I always take it first thing in the morning, just after I get up. I don't know other daytime settings.
Okay. So you may be registering your nighttime, and that may be okay.
Okay. Yeah, that's true. Although that's what they got at the visit this morning with my primary care doctor that was about 11:30.
Okay.
Jim Marshall, go ahead.
Sounds like a time to put on some kind of monitor on you for a couple days to figure it all out.
Mm-hmm.
I would ask for one because I did one and it was very interesting.
You can also get an Aura ring or something like that to monitor Apple Watch. But these Aura rings do great. They graph it and track everything and your VO2 max and everything.
Oh.
Okay. All right, Joe, let us know what happens.
Okay.
Now let's go to Barry.
Hey, the Holter monitor checks your EKG as you're going along. It's a lot more than the ring can do, I think.
Barry, go ahead.
Yeah, I had a question. My doc has me scheduled for a PSMA scan, and my PSA has been undetectable for a while, and so my understanding is that type of scan is not effective unless your PSA is some measurable level.
Not exactly. Not exactly. If we know that you have tumors or you had tumors, those tumors still express or can express PSMA. Even though your PSA is low. So we need a certain level of PSA if we're looking for tumors, we've never seen them before, and we're trying to figure out where is the PSA coming from. But if you've been on treatment for some time, Pluvicto or whatever it is, or in your case, triplet therapy.
Yeah, I've been a drug holiday for 3 years now. And it's been continually undetectable. My testosterone never recovered. But I think she's just concerned, to make sure nothing's going on, even though I'm not registering any PSA numbers. I did have bone lesions some years ago. A few.
Len, you kind of wrote about this, didn't you?
So Barry, it has undetectable PSA, drug holiday for 3 years, and he's wondering if anything might be going on. So under the radar. So yeah, the thing to do is to get scanned with a anatomic scan like CT, MRI, and you could even do a bone scan as well, just to make sure that there's nothing going on. Make sure that you don't have cancer that's simply not producing PSA or PSMA.
Yeah, I've been getting those every 6 months or so, but this is the first time I'm getting a PSMA, and I just thought it was odd that she chose a PSMA when I'm not expressing any PSA. So
yeah, that's unusual, and I wonder. You make sure your insurance company is going to cover that. There was a time when they wouldn't cover it.
Yeah, because when I met with her, she was talking about an Axeman scan, which is what I've had before. But she said PSMA if insurance covers it. And so I'm assuming that they're covering it because I'm going in tomorrow for it. So it's been approved.
Okay.
But I just don't know how effective it's going to be. I mean, that's what I'm curious about.
I mean, it's possible you could be producing PSMA, but not PSA. That's possible. So maybe something would come up, but it's unlikely.
Yeah. Okay.
So to interpret your test under these circumstances, I think you'd have to say that if the scan found something, that would be valid. But if the scan didn't find something, that would not be proof that something isn't going on necessarily.
Yeah.
Right. And that's why when I've had scans in the past, there's been a combination. It's usually been like a bone scan and an MRI or, a couple at the same time, I think, to just overlay them and see if they're both coming up with the same thing. And now just to get a PSMA just seems odd. So.
John, will you explain that to me? I kind of zombied out on you when you just said, I didn't understand that. If the scan shows nothing, that would not prove there isn't something.
Yeah,
What do you mean?
that there's such a thing as a false negative. You know, if you get a scan at a PSA level of non-detectable and it doesn't show anything, you don't walk away and say, okay, that's proof that I don't have any cancer left. You can't do that.
So what do you do under those circumstances? How do you follow it?
You either use a different diagnostic test or you wait until the PSA is higher and retest. Then I was also saying that if the PSMA scan does show something, then it probably is something. Although, you know, every year they come up with a new weird thing that lit up on a PSMA scan but isn't cancer. I saw a report recently about a very bright little bone spur in somebody's back that got a very high SUV on a scan and came up completely negative on a biopsy.
Yeah. Or rib fractures. So would you go to an MRI? Would you go to a total body MRI or something like that afterwards?
I've had those in the past. That's why I'm just a little mystified as to this approach, because that's my same concern. If nothing shows up, then I don't have any other backup scans to, confirm that.
Some people seem to believe the total body MRI is the next step after that to check if your bone marrow is showing any signs of metastasis.
Yeah, I've had those every 6 months or so, that and bone scans and different, everything other than PMSA. So anyhow, it just sounds like this might be a little unusual.
Harry, do you have any symptoms?
No, I feel great. I just have, because of the low testosterone, I have fatigue. But otherwise, no.
I would take it as a win. Don't worry about it.
Yeah, well, I try to, but then when I'm going in for PMSA, it makes me wonder why she's doing that. But anyhow, I'll have to follow up with her then.
Yeah, well, definitely ask her, is this really necessary? Because after all, you are being exposed to radiation.
Yeah. All right. Well, thanks, everybody.
And Harry, make sure, I would just make sure ahead of time that they've got it authorized before you go in there. They've authorized it with your insurance.
Yeah, okay. I'll check. Thank you.
Don't sign anything.
Right. Thanks.
Oh, I'm sorry. Were we speaking with Harry?
Yes.
Yes.
Sorry. Okay. So it's Harry Spieler.
Yes.
Okay. So let's then go to Barry Blomquist.
Good evening, gentlemen.
Hey, Barry.
How are you all?
You're confusing the Barrys and the Harrys are getting us very confused. I was confused to begin with too.
The hearing.
Well, I was puzzled too because I kept hearing him say Barry, and I said, "Oh, we got another Barry in the line. Well, that's cool." Anyway, but Harry's cool too. Don't forget. Well, so I went to Mayo, got my PSMA scan, got my blood work done. PSA is undetectable. They really liked the PSMA scan. It didn't show anything significant change from the last one. And so Dr. Heath was very, very supportive. And so Dr. Hugic at Minnesota Oncology in the Twin Cities, he followed up suggesting the debulking of the prostate, as the group here had suggested would be a good idea. And Dr. Heath concurred in that. And so I'm teed up to go to Mayo in the middle of May and meet with Dr. Phillips there, who looks just like Wyatt Earp. with red hair. And so I guess that's the path I'm going down. And the particular question I've had is Dr. Heath wanted me to make it clear to the radiation guys and Dr. Phillips that, you know, this was palliative treatment, not curative treatment. And, you know, to kind of go a little bit easy on what it is they want to go after, because she said radiation guys and people, whatever. And, you know, they like to shoot things. So what's debulking like? And, you know, what should I look forward to, or what should I say to the radiation docs here about do's and don'ts?
It's just like getting radiation therapy. You won't feel a thing.
Any concern with like, you know, tissue damage to the rectum or anything like that?
They'll be using a sort of a SBRT type protocol, I assume, which will minimize radiating healthy tissue.
Well, I think that's the question. I think that's the question, Barry. I mean, first of all, are they going to be using, what technique are they, do you know yet what technique Phillips would use? Would it be IMRT or would it be SBRT?
I don't know. I haven't met with them yet. But you know, they got lots of guns down there. So
yeah, they do.
My recollection was Dr. Heath kind of suggested that I should do the low dose multiple treatments rather than the fewer dose high level treatments. That was her preference.
Well, I mean, there's a couple of things. The first thing is, I just find it so sad that there they are working in the same institution and she can't get a message to them as to how she thinks she should be treated.
Well, she might have. She did send a message to Phillips within the hour after I left.
Okay.
Because they did set up an appointment to me before I got back to my hotel.
Okay. Well, hopefully she's going to tell them what she would do. She's entitled to have an opinion. If she feels that in your particular case, IMRT would be better than SBRT, then you're going to be looking at 20 odd, somewhere between 20 and 25 low dose treatments. If you can do it with SBRT, it's going to be 4 or 5 treatments. And then the questions are, I mean, I don't know enough about whether they even think I don't think a spacer is appropriate after you've had a radical prostatectomy, because there's nothing to space between. One side's gone. Oh, no, you didn't have a radical, did you?
No. Yeah.
Oh, okay, that's right. So in that case, yes, you should be asking them, do they use a spacer? Do they not use a spacer? That's also a controversial discussion. Some doctors do, some doctors don't, but it's certainly a discussion to have. What else? Jeff Markey, you had your hand up, I think.
Yeah, Dr. Phillips gave a talk on April 8th, the Mayo Clinic monthly talk, and he mentioned they've got 4 proton machines and are putting in 2 more. I don't know if they're considering that, but I just thought I'd mention it. It's supposed to get less radiation. It's really controversial whether that's true or not. He actually said that he has not used it too many times because he feels that it's just the photon is just as good as proton most of the time. But I just couldn't believe they had 4 machines and were putting in 2 more.
Yeah, you guys, you would be absolutely shocked at what's going on in Rochester. They are knocking down 6 to 7 city square blocks at a time around the Mayo Clinic Hospital and rebuilding new buildings. And I mean, every 3 to 4 months when I've gone down there, another block has gone down and another block is coming out of the ground. And, you know, when it gets done, it's going to be 2 or 3 times the size of what Mayo is now. And it's super impressive. And, you know, I guess they're spending $2.1 billion to create, you know, what they hope to be, I think, the largest hospital in the world for treating virtually everything and anything. And I don't know if you guys get the commercials out there, but you know, they run this this series of commercials that say, you know, they're doing the impossible, and it erases impossible and turns it to possible and all that stuff. But Jeff, did Dr. Phillips still have the long red hair?
Actually, I saw him once for only a moment, and then they're having a problem with their display, and they only showed the audience for the rest of the. So I don't remember that, but I remember all the hair. It was interesting.
He's just
John, go ahead.
Character. He also said that he doesn't like to do radiation on anybody who's at over 75 cc's. Their prostate, the big ones. He's done it sometimes, but he doesn't like doing it. It doesn't.
Okay.
Got to get moving, guys. Dr. John, go ahead.
Well, I'll be real quick, Lynn. I mean, just the discussion about what type of technique to use and where to aim it is, as I look back on my notes from when I first met Barry, is a really complicated question. He had SVI, he had ECE, he had neurovascular invasion, he had a possibility of rectal or bladder invasion. And so maybe precision is not what's wanted. So you really do have to have a careful discussion. And the docetaxel has probably quieted all those things way down, you know, judging from the PSA. I was also wondering how Barry, how you're sleeping, but we may not have time to get into that now.
Better, but not good.
Okay.
Okay, yeah, I've got a whole bunch of guys we have to get to, so we're going to move along. Thank you, Barry.
No problem. Thanks, guys.
Let's see, Bob Alvord.
Hello.
Hi, Bob.
A quick update and a little question. I just passed my 1 year of undetectable, still on Lupron and apalutamide. Testosterone is 23 from an initial baseline of 575. Saw my cardiologist because I had an echo and a treadmill a year ago to see if there was any impact from the ADP hormone treatment. And actually my heart's functioning 5% better than it did prior to treatment, so that's good. I have a abnormal low white and red blood cell count. I don't know if that was due to the hormones treatment or the radiation to the spine and lymph nodes back in September, or if there's a recovery period on that. And then lastly, you know, in regards to the radiographic progression without PSA under the enzalutamide study that I think Len put out there or on the email, or I read about in the email, is that kind of suggesting that I should change the apalutamide to darolutamide? And you know, we're always kicking around Lupron and Orgovyx, but is there a compelling reason to change? Because it also said enzalutamide and apalutamide show the highest discordance enzalutamide and apalutamide show the highest discordance. Darolutamide showed the same pattern. And what was interesting, of course, is that they showed a higher incidence over placebo, without the ARSI. So that's the update. Everything's good, but concerned about the crystal ball.
Well, most of us here would probably say that darolutamide is always a good switch from enzalutamide or apalutamide because it doesn't enter your brain. So you don't have the same kind of cognitive issues. You don't feel quite as fatigued. And according to that study that I presented, yes, darolutamide also shows radiographic progression without PSA progression, but to a lesser degree. So I don't know how much faith you can put in that, but just the mere fact that it's a drug that has side effects that more or less parallel placebo side effects.
Okay, and then is there a recovery period for the blood cell counts after radiation? Because mine are abnormal low, red and white.
Yeah, I think that both radiation will lower your blood counts and hormonal therapy will lower them. I don't think anybody can tell you when or if they'll recover. My red blood cells have never fully recovered. My lymphocytes in particular have never fully recovered. They're always on the low side. But everybody's different.
Okay, that's what I got, and I'm just glad that PSA is undetectable for my 1-year anniversary, and I will look in and ask Dr. Rahul. I've asked before, and they said, well, about the apalutamide switch to darolutamide. He says, well, we should see if your heart's doing okay, how'd the echo go and all that kind of stuff. I just had the echocardiogram, and it showed better results than last year's baseline for that. So, but I will again ask about a switch because I don't feel like I have, I do have fatigue, but I don't feel like I have brain fog, but everybody's different.
Yeah.
Okay.
Okay. Thank you.
Thank you.
Richard Fisk, are you still with us?
I am still with you.
Okay, you're up.
Issues are ongoing fatigue and weakness. I was Gleason 4+, 4+5, external beam, high dose brachytherapy, completed Lupron and abiraterone 18 months ago. I still have fatigue, weakness, hot flashes. Testosterone is 169. Just cycled through an endocrinologist who said pituitary gland is working fine, thyroid is working fine, testicles are not responding. Question is, PSA remains undetectable. Question is, what, if anything, can I do? I'm living the virtuous lifestyle with good food and exercise. Dr. Paller says at Sibley said she won't consider testosterone supplement until 2 years after completing hormone therapy. Cardiologist says my heart is good. Question, what can I do to recover, get rid of fatigue, weakness, and hot flashes?
Well, of course, there's always estradiol for the hot flashes.
Mm-hmm.
And being that you're not on ADT, you could probably try the low dose. Dr. Paul's not here to give us a boost on that opinion, but that's a possibility.
Mm-hmm.
Then there's this is the point in time where we ask Jeff Markey to raise his wrist and show us his Ember Wave device.
Yes.
There you go. Have you tried that?
I have barely effective, not a therapeutic dose.
Yeah. Okay. Anybody else have ideas for Richard?
Well, Dr. John, you're still with us. You had a suggestion last time. Do you want to follow up with your suggestion? Do you remember what it was? You have good notes. I know you know what
I
it
don't
was.
remember what it was.
You don't?
I have
Dr.
notes
John.
on Richard, but I don't have notes on what I say.
Oh, well, Dr. John suggested, I think it was Dr. John who suggested anyway, was Wellbutrin. Oh, no, it might have been Dr. Alfredo. Wellbutrin.
Right.
Have you tried Wellbutrin?
I have not.
Okay, do you remember who suggested it? Was it Dr. John or was it Dr.
I think
Alfredo?
it was Alfredo.
Yeah, it wasn't me. Wellbutrin is an antidepressant, but it actually has a little bit of a dopamine promoting, slightly stimulating effect. And Alfredo, I guess, knew somebody who had a very nice change in his perception of his energy level on this drug. It's basically riding side effects, but it helps somebody, and it's not a dangerous drug unless you have a seizure disorder.
I've been talking to a shrink who in fact did prescribe Wellbutrin. I declined based on the fact that in 2003 and 4, I had tried it for a year and didn't like it. Didn't like what it did to me. Of course, that preceded everything to do with the current prostate problems. So
Yeah.
It sounds, I've got some in my drawer. It sounds like it might be worth giving that a shot.
Well,
What
none
did
of
it do
it's
to you back then?
Pardon, Dr. John?
What did it do to you back then in terms of side effects?
I felt, I think, although I didn't record it properly, brain fog.
Oh, yeah, that's surprising with that particular drug. Try it at a low dose. Try it at a low dose and see what happens.
It was a minimal therapeutic dose. That's all I remember. This was, I can't remember what I had for breakfast, let alone what I took 20 years ago.
Which is why you're looking for help anyway. But since you already have the blessing of somebody that you've consulted with, I would see if you experience it in a better way this time.
I'll give it a shot.
Yeah, but don't use the 20-year-old stuff you have in your drawer, Richard.
No, I anything older than 10 years I toss.
Okay.
And let's go to Alfredo. He was the one. Alfredo, go ahead. You were the one who recommended Wellbutrin.
Go ahead.
You're muted.
You're muted.
Sorry about that. I was just going to mention I'm taking Wellbutrin myself. I'm taking the lowest possible dose. And the reason I'm taking it is not so much as an antidepressant, but a PCP suggested for my lack of energy. And so I said, well, okay, I'm willing to try it. Instead of Ritalin, I was taking Ritalin. MD Anderson prescribed Ritalin, and that was okay. It was a little bit of a stimulant, like an amphetamine, but it raised my blood pressure more than I liked. And so the Wellbutrin, it's subtle. I have to say, like many drugs, it's quite subtle, but I think it is letting me have a little more energy. I'm taking the lowest possible dose. It's actually a twice-a-day drug. I'm just taking it in the morning. And
what is the dose you're taking, if I may?
I have to run in the other room and look. It's whatever the minimum.
Probably 75, I'm guessing.
Yeah, I think that sounds right. So 75 once a day, and I think it is giving me more energy. I still kind of hit the wall in the afternoon, but as a prescriber, I've seen Wellbutrin be scary with some patients. I say to them, "Oh no, you're discontinuing that today." I'm sure Len would agree. There's some people who react very badly to it and quickly within the first week, and we say,
It's
"Oh
been
no."
enough psychic energy self-monitoring that if I start going south, I'll notice it.
Yes, and then you're going to stop it right away. So I just anecdotally, in my case, I've never prescribed it very often when I was practicing, and for a lot of people it did. I mean, it's famous as a stop smoking drug, right? It works very well for that. It's famous as an antidepressant. John, you would know better than I how it works for that. And I'm just telling anecdotally, for me, at the suggestion of a PCP, not a psychiatrist, if this gives you a little energy boost, and it seems to be okay.
I will give that a shot. Thank you, Alfredo. Thank you, Dr. John. Len, I'm done.
Okay, thank you, Richard. And by the way, if you go the estradiol route, make sure you get radiation to your chest first.
Too late.
Oh, too late. Okay.
Yeah, I've, as a result of my external beam and high dose, I'm already there.
Okay.
I do have a lovely lacy training bra, though.
All right. Joe Commanda, I was just listening to Alfredo talk about taking Ritalin and getting his blood pressure up. It would probably raise your pulse a bit if you want to talk to your doctor about getting Ritalin.
I can ask. I'm not big on taking drugs, but
yeah. Okay. All right.
Larry has his hand up.
Oh, go ahead, Larry. Sorry.
Thank you. Before I slapped on an estradiol patch, I would definitely check my estradiol levels, and if you're within the normal range, talk to your doctor about it.
Good suggestion.
Yep. Okay. Thank you, Larry. Let's go to Robert Anderson.
Good evening and thank you. I too just saw Dr. Abel in Bethesda, and I'm on the study for the scan now. I had a CT and an MRI beforehand, which was all clear. The scan out there was clear. My issue is actually my PSA. Let's see. In December, it was 1.29. In January, it was 2.8. And last week, it was 8.5.
Ooh.
Yeah, so it's doubling at about a month and a half now. My regular oncologist, Dr. Vanderweel, and I discussed that if it were to go, when it was going up, when it went to between 5 and 10 was when we would start therapy again. I've been on a treatment holiday for a year now. And he was saying most likely, we were discussing maybe monotherapy with daralutamide. Dr. Abel says that we'll wait and see. But I see Dr. Vanderweel in about 3 weeks. So just kind of wondering what you all thought about anything going forward.
Well, I thought the criteria for that trial with Dr. Abel at NCI, you're talking about playing the long game, that one?
Yep.
I thought they said that you would not be a candidate if your PSA doubling time was between 3 and 6 months. Anybody else remember that? Rick, John?
No, it was if it was in between 3 and 6 months, then they say that you would need to start therapy again.
Right.
And there's other studies that are therapeutic studies, drug studies that I could be eligible for as well. Some of them if there's metastases, some of them
yeah, no, I agree with you. If you're under 3 months, you're not eligible. If it's 3 to 6 months, you got to get into some sort of a treatment. And they have some other, they've got that 3-month enzalutamide. They just give you enzalutamide. But I got to tell you, I mean, the first thing is, when was the last PSMA that you did have? Did they do one when you just went down to NCI?
Yeah.
And it
Yeah,
was
it was-
clean?
Yeah.
Have you ever shown anything on a PSMA scan? Has there anything ever been seen?
I've only had one metastasis, and that was to hillier lymph node.
And did that show up on a PSMA scan?
It did. It didn't show up on a CT or MRI. It was on the
Okay. So we think you make PSMA. That's what I was getting at.
Mm-hmm.
Okay. So if we don't see anything on a PSMA with a PSA of 8.5, it's a little unusual, but
That's what I said before. I mean, I've gone up to I think as high as a 10.8, and everything's been clear before going back on treatment again.
Yeah. I mean, if I was going to go on a treatment, and if it were me, I would go on monodarolutamide. Would I trade that off against 3 months of ends to see if something happened?
Well, the other side of that trial is with a I can't remember what it is now, but there's just a 3 months of enzalutamide or with an additional therapy, depending on which arm you are in.
I'm not. Yeah, I know that one option, but I don't know what the other arm of it is. I'd have to look it up.
I could probably tell you, but
yeah,
an immunotherapy. It was with an immunotherapy.
Oh yeah. It was with an immunotherapy. Yeah.
Yeah. So I just kind of looked at it that if I got in that trial, if I just got the 3 months of enzalutamide and nothing really happened, or I needed to continue, I drop out of the trial and continue with the drug. But if I get in that and get the other arm of it.
Yeah, I mean, my response to all of this is it doesn't sound like you're a good candidate for the long game trial right now, given the way that your PSA has been moving. I mean, if it were me, I don't think I would be trying to get myself into that long game trial. I think probably Dr. Van der Wieler's on the money. That's my response. Guys, what are you thinking?
Personally, these numbers are concerning me, and I would like to see, I mean, it would be very nice to see what the minimal treatment you would get away with, but I wouldn't want to be you under those circumstances. If it was me, I'd be after this with doublet therapy now. Go back on, maybe back on Orgovyx, or I'd even be a little nervous just doing mono daro. I'm nervous about these numbers.
I think you're more nervous than I am.
Jeff,
sounds like it. Yeah.
Excuse me one second. Excuse me one second, Jeff G. Just hold on a minute. Given what you just put in there, we'll talk to you, and we'll talk to you as soon as we're done with. Hold in there. We'll talk to you as soon as we're done with Robert. Yeah, I mean, I think you've got to go back on some sort of therapy. Question is, what's the least intrusive? And the least intrusive would be monotherapy darolutamide, and we've had a bunch of guys who have done really well on it. So I think that's what our experience tells us. I think, playing around with NCI when your PSA is moving as fast as it's moving, it's gone up 6 or 7 times from 1.29 in January to 8.5 in April. I don't see you as being a candidate as much as she'd like to have you in that trial.
This has happened in the past too, though, where my doubling time goes, in 3 months to, the last time it was 1.0, and in 3 months it was 6.67. and there was nothing. And then I went back on therapy and back in the same point
Then
again.
we can only tell you what, if you're comfortable with it, then do it. But I don't think we can add anything.
No, I just wanted to hear your.
We really got to move on because it's 7:20 and so
Just a
Len,
quick addendum. We also wanted Robert to see a cardio oncologist someday about an arrhythmia.
Oh, I did. I did do that.
Okay, thanks.
Okay, so you'll update us next time on the cardio oncologist, please, Robert.
Very good. Okay, thank you, guys.
Rick, you wanted to go to Jeffrey G?
Well, I do, because Jeff was about to leave, but is that germline or is that somatic?
I'm sure it's in the report. I just don't know where to find that.
Do you understand the difference between the two, Jeff?
No, I don't actually.
Okay, so germline means you inherited it from one of your parents.
Right.
Somatic means that you have developed it yourself. Where
it's germline then.
It's germline.
Yeah,
okay.
Yeah.
So that has a lot of connotations. We will definitely add you to the BRCA Brothers list, and we have another group. We have a group that meets quarterly. It requires that you monitor yourself for several cancers, not just prostate cancer.
Right.
But you have to keep an eye on breast cancer, on melanoma, on pancreas cancer. Those are the really important ones. And you have to get into a regular program to do that monitoring. I don't know who, I would not be comfortable with a local doctor alone here. You need a doctor a medical oncologist who also is pretty familiar with BRCA issues. So it's significant. It's pretty significant. Do you have cancer in your family? Any other cancers in your family that you know of?
Yeah, both parents, both of their one side of each of their parents. So it's very hereditary. Breast cancer and pancreatic.
And pancreatic, yeah.
Ovarian. So,
yeah. So all of those Ashkenazi Jews, I'm guessing.
I don't know. Yeah.
Yeah.
Well, I don't know. Does that have to do with race?
Yes. Okay. There's a much higher prevalence amongst Ashkenazi Jews. And so they're considered to be a risk category. So they recommend that if you have cancer and you are Ashkenazi, you get germline tested. But first of all, I'm glad we found it. I'm glad we lent on you to make sure you got it, because it can be a lifesaver. What is your doctor saying to you right now?
Yeah, it was just last week, so I haven't gotten any information from him. He hasn't responded to the test results. But
well, again, it's important enough that they should be right on it. If he's not talking to you about regular testing for a bunch of other things, is Marky still with us? Are you still with us, Jeff, or not? Yeah,
I'm here. I'm here.
Yeah. So Jeff will tell you in a second because he's BRCA2.
Ashkenazi too.
But I think if it were me and I was living in Tucson and I found I was BRCA2 and already had a cancer, I'd probably enlist another quarterback on my team. if I can make the insurance, I can make it work with my insurance. And we could talk about who and where.
UCSF.
UCSF.
Yeah, UCSF is my first, but Dr. Munster is leaving, but I don't think it's going to be the end of the program there. But probably UCSF and probably Dr. Agarwal would be who I would refer you to, and have him really try and help you put together a program to make sure you're doing regular monitoring. The UCSF BRCA Center for BRCA Research does have a program, and they will remind you when you need to do tests and what tests you need to do, and that's really what you need to be doing. It's not something you can sit on. Jeff Markey, do you want to say something about the testing that's needed?
Well, I just had an MRI for pancreatic testing last week, and your doctor should be doing checking your chest for breast cancer problems every year. Those are the main ones that men have problems with that I know of. There's melanoma, I think, is another one, but
yep,
you just have to keep track of your skin
So-
and see what's going on.
Here's what we're going to do, Jeff. We will add you to the BRCA Brothers email distribution.
Okay, thanks.
And we will add you to the inherited mutations reminder, which is, we just had a meeting and it's only once a quarter, and it's wider than just the BRCA Brothers. The BRCA Brothers are basically our guys who have inherited mutation and also prostate cancer. Once you're on that BRCA Brothers list, and I'll send you a note, I would send a note out to all of them. They're all really kind and helpful, and say, how do you think I should manage this? And let them give you some advice from peer experience as to what to do. I think that's as good a starting point as any. And then people like Markey and Sal. I mean, there's a whole bunch of them and they'll give you solid advice. But I think that it's a wake-up call for you that you must pay close attention to monitoring all these cancers. Because if you monitor them early and you catch them, you can deal with them. But they can creep up on you, and all of a sudden you don't know, and then all of a sudden you find, oh my gosh, I've got a lump. I know what else I'm going to do. I'm going to tie you in to Bill Harris. Okay. I will introduce you to Bill Harris, and I'm going to ask Bill if he will help navigate you. Bill has had, he doesn't have serious prostate cancer. It's very early, but he has had breast cancer, and he's had he's had a mastectomy. I don't know if it's a double. And he's also had some pancreatic cancer issues. He's a really good guy in Los Angeles. So I will also make that introduction for you tomorrow.
Super. Thanks, Rick. Yeah. Yeah. Things, with the holiday, 2 weeks into this holiday, I'm thinking there may be some adjustments to make. So I'll be doing my research and finding out the best path.
Adjustments on the drug holiday you're talking about?
Well, not on my own, but I'll talk to the doctor, and I expect he's going to make an adjustment. Do you think?
Well, I mean, you were on Eligard and Daro. When did you start the drug holiday?
2 weeks ago.
Okay.
That was 6 months in.
So you did, how long did you do the Eligard and Daro for?
6 months, a little over. And I was at less than 0.01 PSA.
Are you getting monthly tests, Jeffrey?
No.
My PSA went from 0.2 to 1 in 18 days when I went from 4 Zytiga pills to 3. BRCA2 is that aggressive on me, at least. So you're dropping darolutamide. I mean, I was able to drop my ADT, and darolutamide kept me undetectable for 8 months. But I know if I drop that, my PSA is going to start rising like a rocket. You want to make sure you get tested regularly.
Yeah. Okay. Thanks, Jeff. Oh, thanks for letting me jump in, guys. I know there's some other people in line. But,
all right. But I think we need to. We need to get you with a really solid doc. I think that's the most important thing.
Yeah, I can travel and do the research on the insurance. Cool. Thanks, guys.
Thank you, Jeff. Jay, you have something to add?
Yes, we have BRCA2 in my family, and I did not inherit it. And but in recommending that everybody get tested, all the generations above and below, but especially the below, when you have people that are young, looking at having children, it gets to be just a daunting subject, and one that can be very, very heavy to talk about. So if you are, certainly let all of your relatives know that at the right time, but be prepared to offer them professional counseling.
Yeah,
because it can be very, very, very traumatic.
And that's why we run. And Jay, any of your people can join our inherited mutations group as well. That's why we run that inherited. Do you have kids, Jeffrey?
No, I do not.
Brothers and sisters?
Yeah, older.
Cousins,
no known
aunts, and uncles.
Cancer with them yet.
You want to have your cousins, aunts, and uncles need to be tested if they are if they're part of that heritage. I had both of my cousins that are still alive were tested. My brother and sister, both of my kids. It's essential.
Oh, my niece is terminal. She's in the last stages of breast cancer. So yeah, it came too late there.
My cousin died at 16 of it, and her mother died of it. My other aunt got it, and she fortunately lived. But my mother never had anything, but gave it to me.
Okay, let's move along because it's getting real late. Len, how many more people do we have?
I've got 2. Danny Langford, I know, is here. If David Seattle, are you still here?
Yeah, they're both here. Len, I'm willing to stay if you. I know it's late for you.
It is. So I think I'll turn it over to you.
I'll close it out. So
you got Danny, and then David.
Okay. Do you know which order they came in?
Danny first, and then, well, David, I can't remember exactly when he came in, but he kind of said, put me at the bottom. So.
Okay. So Danny and then David, and I'll stay as long as it takes. Danny, you first.
I'll keep it short, fellas.
Okay.
I want to first commend you all for your stamina. You guys, it's like 2.5 hours here, and I'm 50 and exhausted. So bravo for your stamina. All I want to say, because of time, I'll come back next week or the next session and give you an update. But I start chemo on Friday, and just wish me good luck on that. Rick, your advice was helpful. It changed treatment.
Say that again, Danny.
I said your advice was helpful. It changed the treatment path. It was radiation and ADT, and they didn't catch that TP53 gene. And then I went and talked to another individual, and we kind of looked at that. And he's like, wait a minute, that's resistant to ADT over the long term, so we need to consider chemo. And I accepted it right away, and that was last week. And so I start that on Friday. The Mayo folks and Dr. Hugic and Dr. Heath, they didn't bring it up to me, and I was kind of curious why they didn't mention it. They didn't recognize that as a sequencing. So, you know, it's ADT, it's chemo and radiation all back to back. But,
Okay.
you know, had we not found that, I would just be going with radiation and ADT for now. So anyways, thank you, and I'll update you next week.
Are you going to take a medical leave? Are you looking at the wife? Is that who you're looking at? Are you looking at the wife?
I'm looking at my work calendar.
Oh.
So the short answer is maybe, but I won't travel, and I have reserved the ability to do some reasonable accommodations around timing. But as of right now, I don't have any plan to stop working, and that's where not yet. If I feel I need to, I will. I've got it there.
Okay.
I can use it.
So a couple of things. The first is the chemo, especially if you've been pretty healthy and you're strong like you are, chemo may not catch up with you for 2 or 3 sessions. So don't think just because you sailed through the first one and you did well on the second one that it's not going to catch you, because it can come back and whack you behind the head. So I want you to know that, right? Secondly, follow RJ's advice. All right. I know you're in touch with him. He's great. He did so well. He did take medical leave because he had a pretty high level job at Microsoft. And that's worth thinking about. And the other thing he did, which I really want you to talk to him about, is he did the icing. So he bought an ice cap and he iced his fingers, and I don't know what else he iced, but he did very well doing that. And please reach out to him. If you don't have his phone number, send me an email right now and I'll send it back to you tonight. Call him. He's not a lot older than you are. He's in his 50s. And I feel like he did real well tolerating the chemotherapy. I think he'd agree.
Okay.
And so those are the 2 most important. Don't hesitate to ask, because of what's going on behind the scenes that you're helping us with Dr. Munster. She's offered to help you. Don't hesitate to reach out. She's wonderful. She's very, very knowledgeable. And also make sure you are enlisted at Masonic with the palliative care group. Have them on your team right from the beginning, because if you are having issues with nausea, if you're having issues with bad tastes in your mouth and all of that, they're going to be much more accessible, I suspect, than Dr. Antanarachis, and they're there to help you. This is exactly what they're there for. And rather than waiting, tomorrow, reach out and say, I want to have a palliative care practitioner on my team now. So those are my 3 points. That's some of my advice, Mr. Langford. Anybody else who's been through chemo got any other advice for Danny?
No problem. He's a Marine. He can handle this. Trust me.
Thanks, Captain.
Well, that's what I'm worried about. That's exactly what I'm worried about. He can handle it until he can't handle it. And so I would like to be thinking about this ahead of time. Gary Martin, do you want to say anything about the freezing business?
Yes. I think that's important to do. Help avoid neuropathy, minimize it. I found we had the best luck with the gel packs. We have bought some equipment that circulated ice water, but those didn't hold up as well as the gel packs.
And did you use a head to keep your hair, one of those ice bonnet things?
No, I didn't. I don't have any hair anyway, so not an issue.
Look, Rick, I already started the process. I shaved it already, so I'm out ahead of it just in case.
Okay, you got to start.
Look, RJ finished up with a full head of hair. Started with a full head of hair and finished with a full head of hair. So God bless RJ. He was really good on that. So, but listen to Gary, listen to RJ. Any other chemo vets in here that want to contribute anything? Okay.
Thank you, guys. David, get after it.
Okay.
Hey.
Can
you hear me now?
Well, now you're very, very faint, David, but I can barely hear you. Speak up.
Any better? Is this better?
Not really, but I'm trying. I'm turning my volume up, and I don't know what's going on. Let me.
Is this any better?
That's worse. I feel like I'm in the. I feel like I'm in the optometrist's office here. That's.
Is this any better?
Not really, but keep talking, and I'll get you to repeat if I can't hear you.
Okay, so this is a follow-up to the tail end of last week's meeting. We were talking about my situation, and you were discussing some alternative.
Now you've gone all together. Now I lost you all together.
What?
Now you're back.
Okay.
I don't know what's going on there.
Well, so I'm following up on a discussion that was
Yes.
at the tail end of last week.
Right.
And you guys were discussing amongst yourselves some options or possibilities for a second opinion.
You need names. And I dropped the ball, didn't I? I never sent you an email.
I did not see anything come through, no.
No. And I realized that because it's on my desk, and I was going to do it today, and then it got crazy. So here's the good news.
Yes, sir.
The good news is that I spoke to Dr. Evstathiou, and she said she'd be happy to talk to you. And I need to send you that information so that you can reach her.
Okay.
Okay?
Thank you.
So you're currently getting your treatment from Cheng, correct?
Yes. Yes, Heather Cheng at Fred Hutch.
Right. So we can't move you anywhere in Fred Hutch. So ideally, but I don't know when she's going to be ready, Dr. Evstathiou would be my first choice at OHSU. And I promise I will send that to you tomorrow. I'll get that out to you, and I'll tell you how to get hold of her, and you'll tell her that you're the person that I texted her about last week. I didn't forget you. I forgot to follow up with you. And I truly am sorry.
Yes, no worries. I wasn't expecting anything. I thought that
No, you should expect. I told you I would do it, and I don't know. It's been crazy here. We've been trying to get sponsorships out, which I'm still trying to do. So it's been a lot of pressure. The other person that the other alternative I think I was thinking about, and I've got Dietmar, because I got it written down here. Dietmar, I got it on a piece of paper here. I think the other person I was thinking about, here it is.
Was Antanerakis?
Yeah, no. Well, yes, Antanerakis was one, and the other was Rahul. Dr. Agarwal in at UCSF. Because you have a mutation, don't you? I can't remember what it is. P10? Yeah, P10.
Form and IDC.
Yeah. So I would think first choice would be Eleni. Second choice would be Dr. Agarwal, and I'll give you his information. And third choice, because he's just good on these, as you just heard from Danny, he's good on these the bad boy mutations, TP53, RB1, and P10. Would be Antanarakis, but he's in Minneapolis, which is a little bit further for you to travel. And they're all great docs.
Travel is not an issue at all.
All right, I'll lay it out for you tomorrow. And again, my apologies that I didn't get you to it before.
No worries. Thank
you.
For
David, if I could share, if I could give back a little bit, share my experience. I went through 3 different organizations, oncologists, to evaluate my case since I was diagnosed in stage 4 with Gleason 10, Pirates 5, and it was pretty advanced and high risk. No one talked to me about these genetic mutations at Mayo, Rochester, and I know they're great people and everything, but once I talked to Dr. Antanarakis at Masonic, within like 5 minutes of talking to him, I noticed a difference. I noticed a perception of my case. I noticed, he picked up on details that the others didn't. I don't know why they didn't, but he did. And so, I'm just sharing. My wife's a doctor. I study biology and chemistry, and so we have sort of this this awareness of this subject matter, at least to some degree. And so, the difference in how he interacted with me and evaluated my case, and the confidence in identifying those nuances about the genetic details, it was just so fast and rapid. And I'm just sharing my story here. Within moments, I knew, all right, that's my quarterback, that's my guy.
Yeah.
He's going to lead this.
And I can safely say that would be, you would get that same response from Dr. E or from Dr. Rahul, because this is where they're really good. I didn't send Danny to Dr. E or Dr. Rahul because he's in Minneapolis. But if you were next to Dr. Antanarakis, I would have sent you there in a heartbeat. But I think from where you are, any one of those 3 is going to respond very well. I don't get the way that Dr. Chang has really managed your case. At the same time, I also don't get why she didn't test you until relatively recently. It's weird. It's weird. I think the best fit for you would probably be Eleni. But it also comes with when she's going to get her blinking license, because they've been messing her around in Oregon forever and a day. And, she's licensed in Texas, but she's been hired to run all of genitourinary oncology at OSHU.
Okay.
Oh, Oregon Health, OHSU. Yeah. Oregon Health and Science, and she's really, really good. But I promise I would say Rahul or Eleni, and our fallback should be Dr. A. And we'll get you in quickly to Dr. A. Danny will make sure about that.
Okay.
I'll mention it.
What did you say, Danny?
I'll mention it next time we're together.
Yeah.
And Rick, you got some kudos from Dr. Antanarakis. He said he was going to work on an honorary MD for you. He said that guy is something else. Talking about you.
That's very nice. I was really so pleased to shake his hand in San Francisco this year because we've been with him with one patient or another since he was at Hopkins. What year did you see Antanorachis, Jay?
18.
18.
Yes.
18. Yeah. We go back with him a long. We go back with him a long way. All right, guys. Anybody else? Did I miss anybody? Does anybody else have a question? I'm getting my second win before we close this out.
Rick, Danny had a question about RJ's name.
Oh, RJ Smith. Do you not have it? I'll send you all of his details. Do you remember
It was in my notes. I just didn't write his last name, so I didn't want to go hunting for his name. Thank you. That's what I needed.
Okay. Do you have his telephone number as well?
I had his name. I don't have a number.
Okay. I'll send you name and contact information right afterwards, Danny.
Okay. Thank you, sir.
As time is of the essence here, and Gary Martin's sticking stuff like there's no tomorrow in the chat window there about cryotherapy. So have you guys exchanged email addresses? Make sure you've exchanged contact information, please.
We were chatting right now, but I was sending him direct private message to Gary, and he was responding to everyone. That's why you see his activity and not mine. Sorry.
Oh, okay. Well, make sure you get his. Gary, send him your contact details, or if not, I'll give them to you. Oh my gosh! And look, Dr. Alfredo is still with us at this time. I can't believe it. He gets a special prize.
As soon as we're done, I'm crashing. I'm telling you, I'm going to be out.
Okay. All right. Anybody else? Final call.
Yeah.
Thank you.
Good night, everybody. Good night. Good night. Good night. Good night.
Bye, guys. Thanks.
Download the chat. Download the chat. All right. I'm ending the session. I hope you got the chat.